Welcome to our video on systemic lupus erythematosus. Let's begin. In this lecture, we're going to cover the definition, pathogenesis, risk factors, classification, clinical features, diagnosis, management, and prognosis of systemic lupus erythematosus. Systemic lupus erythematosus is a multi-organ autoimmune disorder that primarily involves skin, joints, serosal membranes, blood cells, nervous system, and kidneys. Women of childbearing age account for the majority of the cases. However, when men present with the disease, it has a more severe outcome. The disease is more common in women due to estrogen, which can trigger the B cells of the immune system to produce antibodies against DNA. It is more common in people of African, Asian, and Hispanic ethnicities compared to those of Caucasian ethnicity. The pathogenesis behind the disease is caused by an autoantibody production, deposition of immune complexes, complement activation, and accompanying tissue destruction and vasculitis. Let's discuss the risk factors. There are certain HLA associations that are more common in people with systemic lupus erythematosus than in the general population, like HLA-A1 and HLA-DR3. Inherited deficiencies of certain complement components like C1q and C2 can also increase the risk for developing systemic lupus erythematosus. There are some environmental triggers which are known to cause the initial onset of the disease or exacerbation of it, like infectious agents and ultraviolet light. Infectious agents include Epstein-Barr virus. Ultraviolet light can act as a trigger for autoimmune disease and is specifically important in producing the characteristic malar rash. Drugs such as procainamide and hydralazine can cause drug-induced lupus. As for the categories of lupus, we can summarize them into 4 types. Spontaneous lupus, which can be idiopathic in origin or triggered by environmental factors. Cutaneous lupus erythematosus, which presents with skin lesions in the absence of a systemic disease. Drug-induced lupus, which we mentioned is caused by drugs like procainamide and hydralazine. And lastly, anti-nuclear antibody negative lupus. Despite the anti-nuclear antibody negativity, these patients can have anti-Rho SSA antibodies. Let's mention briefly the characteristics of drug-induced lupus. Antihistone antibodies are present and are key characteristics of drug-induced lupus. Through unclear mechanisms, the associated drugs induce immune reactions against histones. Autoantibodies are then developed against histones, producing a temporary lupus-like syndrome. Double-stranded DNA antibodies are rare in the drug-induced lupus. Also, decreased serum complement levels is uncommon. There is a low incidence of renal and central nervous system involvement compared to other types of lupus. And lastly, the symptoms and laboratory test results will disappear once the drugs are discontinued. As a quick reminder, the mnemonic SHIP could help you remember the 5 common drugs that cause drug-induced lupus, which are sulfasalazine, hydralazine, isoniazid, procainamide, and phenytoin. All right, let's do a flash quiz. A 27-year-old female is diagnosed with drug-induced lupus. What features can distinguish this condition from other types of lupus? This patient is diagnosed with drug-induced lupus. Let's discuss how we can distinguish drug-induced lupus from other types of lupus. The drug-induced lupus is characterized by anti-histone antibodies, while primary lupus presents with anti-Smith and anti-double-stranded DNA antibodies, as we'll discuss later. Another important factor is that for drug-induced lupus, there is a complete resolution of symptoms after drug discontinuation. The symptoms of systemic lupus erythematosus can be very broad, since it's a multi-system disease. Let's break down these by system. Patients present with constitutional symptoms like malaise, fever, and weight loss. Involvement of the lymphatic system can present with generalized painful lymphadenopathy and splenomegaly. As for the hematologic findings, fatigue, pallor, petechia, and recurrent infections due to pancytopenia can be present. Musculoskeletal findings are often one of the first complaints. Among these are myalgia and arthalgia, with morning stiffness in the wrists. Arthritis is also seen at the proximal interphalangeal and metacarpophalangeal joints bilaterally. This arthritis is usually symmetric, non-erosive, and non-deforming, which can be useful to differentiate it from rheumatoid arthritis that is deforming. Let's talk about the mucocutaneous findings. UV light exposure, as we mentioned earlier, either initiates or exacerbates the rash. This is called photosensitivity. A characteristic butterfly-shaped malar rash over the cheeks and bridge of the nose sparing the nasolabial folds is commonly seen. Patients can present with discoid lesions, which are erythematous raised patches with keratotic scaling. Alopecia is hair loss that can be permanent and is due to the development of discoid lesion scars on the hair follicles. Finally, there are oral and nasopharyngeal ulcers. Raynaud phenomenon can be seen as well, which presents with the discoloration, numbness, and pain of fingers as a result of vasospasm in settings of cold temperatures or stress. Here's an image of the malar rash. Notice the butterfly shape and how the rash spares the nasolabial area. Now let's take a look at what Raynaud phenomenon looks like. Notice the clear demarcation as seen here, and also see the discoloration of the fingertips due to vasoconstriction and lack of oxygen flow. Here are two variants of discoid lesions. The image on the left shows alopecia caused by discoid lesion scars on the hair follicles, and the image on the right shows classic discoid lesions, which are erythematous raised patches with keratotic scaling. As for the renal findings, the kidney is the most common visceral organ involved in lupus. Diffuse proliferative glomerulonephritis is the most common and severe glomerular disease. It presents as a nephritic syndrome, with findings like hematuria and hypertension. Patients with lupus also present with nephrotic syndrome and proteinuria, as we will discuss in the laboratory findings. Chronic renal failure is a common cause of death in these patients. The gastrointestinal findings include nausea, vomiting, dysphagia, and peptic ulcer disease. Let's take a look at this histologic image of diffuse proliferative glomerulonephritis. It is commonly found on a kidney biopsy of patients with lupus nephritis. Please notice the increased mesangial matrix and mesangial hypercellularity of this glomerulus. Moving on to the cardiovascular findings. The most common finding is fibrinous pericarditis, which can be seen with or without effusion. Liebman-Sachs endocarditis is also characteristic of lupus. It is a type of non-bacterial thrombotic endocarditis, which usually affects both sides of the valve. Over the mitral valve surface, sterile vegetations can be present, which can cause valve deformity and mitral valve regurgitation. Antiphospholipid syndrome can be found in patients with SLE. This leads to vessel thrombosis and stroke occurrence. Let's take a look at this illustration. As we mentioned already, Liebman-Sachs endocarditis is a type of non-bacterial thrombotic endocarditis with sterile vegetations on both sides of the valve. These vegetations can cause valve deformity and mitral valve regurgitation. When it comes to the respiratory system, the most common finding is pleuritic chest pain, which can be seen with or without an effusion. Interstitial fibrosis can also occur, and this leads to restrictive lung disease. As for the neuropsychiatric findings, cognitive impairment and headache are amongst the common neurological manifestations. Seizures, psychosis, and strokes can also be present. Lastly, let's briefly cover pregnancy-related findings. Recurrent spontaneous abortions are of frequent occurrence. And as we mentioned previously, this is a complication of thrombosis related to the presence of antiphospholipid antibodies. During fetal development and newborn stage, there can be a complete heart block. This is due to the maternal anti-Rho and anti-LA antibodies crossing the placenta and attacking the heart conduction system of the fetus. Let's do a flash quiz. A 1-day-old newborn male is evaluated by the pediatrician due to diffuse rash. He was born at 39 weeks gestation to a 26-year-old mother with systemic lupus erythematosus. His physical exam reveals erythematous maculopapular rash, most prominent on the face. Complete blood count is significant for hemoglobin of 10, white blood cell count of 5,000, and platelet count of 90,000. Serum AST is 800, and serum ALT is 550. Electrocardiogram shows complete dissociation of atrial and ventricular depolarizations. What is the most likely cause of this newborn's ECG finding? This newborn presents with diffuse rash, pancytopenia, high levels of transaminases, and atrioventricular dissociation on ECG. These are the classic signs and symptoms of neonatal lupus. Neonatal lupus is even more likely given the fact that his mother has systemic lupus erythematosus. The complete dissociation of atrial and ventricular depolarizations is consistent with third-degree heart block. Heart block in neonatal lupus is caused by the transplacental transfer of maternal anti-Rho SSA and anti-LA SSB antibodies, which damage the cardiac conduction system of the fetus. The diagnosis of systemic lupus erythematosus is based on both clinical and laboratory criteria. As we discussed the clinical features in the previous slides, let's now move on to the laboratory testing. The best screening test for lupus with high sensitivity is anti-nuclear antibodies. However, these are not specific to lupus and can be present in other diseases. On the other hand, anti-double-stranded DNA and anti-Smith antibodies have high specificity but low sensitivity. Therefore, they are not very useful for screening. Antiphospholipid antibodies can also be positive, and these can result in false positive rapid plasma reagent test for syphilis. Antihistone antibodies will be found in drug-induced lupus, as we mentioned earlier. Anti-Rho SSA and anti-LA SSB antibodies can be found, but these have a low specificity and sensitivity. These are strongly related to the risk of neonatal lupus in pregnant women, as we explained earlier. Erythrocyte sedimentation rate is typically elevated in patients with SLE. The complement levels of C3 and C4 may be decreased. Complete blood count typically shows anemia, leukopenia, and thrombocytopenia. Proteinuria of more than 0.5 grams per day may be seen in the context of nephrotic syndrome, and red blood cell casts or hematuria can be detected in the context of nephritic syndrome. Okay, let's go through a flash quiz. A 21-year-old female comes to the physician due to chest pain for the last 3 days. Her pain gets worse when she inhales deeply or lies down and gets better when she leans forward. She also noticed joint pain and warmth in her wrists, knees, and hips. She has a past medical history of facial rash worsening with sun exposure. Which two antibodies are most specific for this patient's condition? The patient presents with chest pain, getting worse with deep inhalation and lying down, and getting better with leaning forward. This pattern of chest pain is classic for acute pericarditis. Additionally, she has diffuse arthritis and facial rash worsening with sun exposure. All these findings indicate the presence of systemic lupus erythematosus, SLE. The two most specific antibodies for SLE are anti-double-stranded DNA and anti-Smith antibodies. When it comes to the treatment, a non-medicated measure the patient can take is to avoid sun exposure. This can prevent exacerbation of the malar rash and further UV light damage. Non-steroidal anti-inflammatory drugs and corticosteroids are used for arthritis and to reduce inflammation and additional flares. Oral steroids are used for mild symptoms, while intravenous steroids are prescribed in cases of organ damage. Hydroxychloroquine, which is an anti-malarial agent, is best used as long-term therapy for cutaneous, constitutional, and articular symptoms. It can be used as maintenance therapy after resolution of acute symptoms. However, due to potential retinal toxicity, patients on maintenance therapy of hydroxychloroquine need annual eye exams. If the patient presents with severe symptoms or major organ involvement like glomerulonephritis, immunosuppressive drugs can be used, such as cyclophosphamide or mycophenolate. Drugs like hydroxychloroquine and cyclophosphamide take some time to exert effect, which is why the initial administration of corticosteroids helps during the acute flare. Let's do another flash quiz. A 28-year-old female comes to the physician due to severe fatigue for the last 5 months. She used to play tennis, but now feels like she can't even walk up the stairs to her apartment. She also has pain, swelling, and warmth in her wrists, which further interfere with her exercises. She has also noticed a rash involving her nose and cheekbones that gets worse with sun exposure. She is diagnosed with systemic lupus erythematosus and prescribed hydroxychloroquine. To monitor potential side effects of this medication, which test is recommended to perform on an annual basis? This patient presents with severe fatigue, presumably due to anemia. She also has bilateral wrist pain, swelling, and warmth. Additionally, she complains of a rash involving her nose and cheekbones and getting worse with sun exposure, which is the classic description of a malar rash. Therefore, she is diagnosed with systemic lupus erythematosus and prescribed hydroxychloroquine for long-term control of her disease. Hydroxychloroquine can cause retinal toxicity, so the annual eye exam is recommended for this patient. Let's talk about prognosis. Although there's no cure for lupus, the disease in some patients can go into remission. Due to new guidelines and advances in both diagnostic and treatment measures, there is an improved survival rate. The majority of patients have a 5-year survival rate. The most common cause of death in patients with lupus is infection due to immunosuppression as well as the chronic renal failure. Let's end this lecture with a question. A 35-year-old female comes to the physician due to acute worsening of her diffuse joint pain. She's had the joint pain for 7 years. She complains of pain, warmth, and swelling in her wrists, hips, knees, and ankles. She has a past medical history of recurrent seizures and non-infective mitral valve endocarditis. She has had pneumonia 5 times during the last 7 months. She does not take any medications. Her vital signs include a temperature of 38 degrees Celsius, blood pressure of 160/100, heart rate of 87, and respiratory rate of 16. Her serum creatinine is 8, while her blood urea nitrogen is 50. Which of the following is the next best step in the management of the acute phase of this patient's condition? A. Cyclophosphamide, B. Corticosteroids, C. Hydroxychloroquine, or D. Ibuprofen. This patient exhibits the classic signs and symptoms of acute lupus flare. She has diffuse joint pain. The non-infective mitral valve endocarditis is consistent with Liebman-Sachs endocarditis. Additionally, she has had pneumonia 5 times during the past 7 months, likely secondary to leukopenia. She also had recurrent seizures, most likely due to central nervous system involvement. On the other hand, hypertension and severely increased creatinine and blood urea nitrogen can be explained by nephritic syndrome, most likely diffuse proliferative glomerulonephritis. Now the question asks the best next step in the management of acute lupus flare. Lupus flare is usually treated with high-dose corticosteroids, so the correct answer is option B. This is the slide we discussed earlier in this lecture reminding us of the management of lupus. Let's discuss why other options are incorrect. Option A, cyclophosphamide, and option C, hydroxychloroquine, are incorrect because they are disease-modifying drugs and take time to yield effect. They are not used in the management of acute lupus flare. Finally, option D, ibuprofen, is incorrect because although it has analgesic and anti-inflammatory properties, it is not as effective as corticosteroids for acute flare of lupus. And that concludes our lecture on systemic lupus erythematosus.